Okay, let's dive into this explainer and play a little medical detective. Today, we're setting out to solve one of the ultimate clinical puzzles out there, the human abdomen. I mean, think about it. When a patient walks in clutching their stomach, they're basically presenting us with a locked box of mysteries. You've got dozens of organs packed into this really tight space, and the clues? Well, they're usually kind of vague, confusing, or totally overlapping. But by using structured, algorithmic thinking, we can actually decode exactly what the body is trying to tell us.
To do that, our investigation today is going to proceed top to bottom. We'll be covering the medical detective, upper GI mysteries, decoding gut bleeds, lower GI suspects, the acute abdomen, and finally, the final diagnosis.
Section 1. The medical detective, charting the territory. Before we can identify the culprit, we really need to know the layout of the neighborhood, right? And this beautifully simple 4-quadrant map, it's basically our treasure map. It helps us instantly visualize which organs are our primary suspects just based on exactly where the pain strikes. So if a patient points to their right upper quadrant, our brain should immediately jump to the gallbladder. We're thinking cholecystitis or biliary colic. Pain settles in the right lower quadrant, the prime suspect is acute appendicitis. Mid-epigastric pain that radiates to the back, we're looking straight at the pancreas. This map is literally step 1 in taking a totally chaotic symptom and narrowing down our suspect list. Now, the really crucial point here is knowing how to interrogate these suspects without causing the patient more harm. In clinical medicine, we always have to distinguish between the best initial test and the most accurate test. The best initial test is usually fast, it's safe, and it's non-invasive. Think like an ultrasound or an X-ray. It points us in the right direction, but it's rarely the final word. The most accurate test, on the other hand, gives us the definitive diagnosis, but it usually involves, sending a camera down a patient's throat or taking a biopsy. So our job as the detective is to bridge the gap between those two. Moving on to Section 2, Upper GI Mysteries, from the esophagus to the stomach. Let's head into our first specific suspect zone. Here's where a simple, safe initial test can visually prove two entirely different conditions. On one side, we've got a barium swallow showing achalasia. Notice how the lower esophagus dramatically tapers down to a point? We actually call that the bird's beak. It happens because the lower esophageal sphincter has literally lost its nerve supply and just completely refuses to relax. On the flip side, we see an esophageal spasm. The barium reveals this chaotic, twisting, corkscrew pattern as the esophageal muscles are just spasming wildly. So that's two very different causes of difficulty swallowing, diagnosed beautifully by their visual signatures alone. Moving just a bit further down into the stomach, we hit peptic ulcer disease, or PUD. Now, if a patient has burning epigastric pain, we might naturally suspect an ulcer. But listen, here is the medical detective's absolute golden rule. If you suspect a gastric ulcer, you cannot just rely on an X-ray. You must use an upper endoscopy. Why? Because a completely benign gastric ulcer can look absolutely identical to gastric cancer. Endoscopy with a biopsy is literally the only way to definitively rule out malignancy. Okay, so once we've done that endoscopy and confirmed it's just an ulcer, we usually find a microscopic accomplice, the bacteria Helicobacter pylori. If H. pylori is in there, our treatment algorithm demands a really strict, step-by-step eradication protocol. You can't just give them one drug and call it a day. You have to hit it with a proton pump inhibitor, plus clarithromycin, plus amoxicillin. Oh, and if they have a penicillin allergy, we just swap that amoxicillin out for metronidazole. It's a highly calculated multi-drug strike designed to completely clear the infection and cure the ulcer. All right, Section 3, Decoding Gut Bleeds, a race against time. Sometimes, you see, our mystery involves severe gastrointestinal bleeding, which completely and totally shifts our investigative priorities. When blood is actively leaving the vascular system, we definitely don't have time to ponder maps. We are in a literal race against time. It's actually fascinating how the body's simple physical vital signs act as this real-time gauge of internal hemorrhage. We don't necessarily need some fancy lab test to tell us a patient is in critical danger. If a patient is bleeding and their resting heart rate jumps over 100 beats per minute, or their systolic blood pressure drops below 100, that is a massive clue. It tells the detective that the patient has already lost a staggering 30% of their total blood volume. Which actually leads us to a bit of a paradox in medical investigation. Identifying the exact source of a severe GI bleed is actually not your first priority. I know, right? Your absolute first priority is keeping the patient alive. 80% of GI bleeds will stop completely spontaneously if we just immediately prioritize rapid fluid resuscitation with high volumes of normal saline or Ringer's lactate. You basically have to fill the pipes back up with fluid before you start sending cameras down to find the leak. Most patients who don't survive a GI bleed, they die from inadequate fluid replacement, not from a lack of diagnosis. Section 4, lower GI suspects, the bowels. Assuming our patient is stable now, let's head further south. Here we encounter the incredibly complex web of lower GI conditions, primarily involving the small and large intestines. This area is super notorious for tricky infections and chronic inflammation. For instance, let's look at how we build a case for a very specific suspect, Clostridioides difficile, or C. diff. This is a severe diarrhea that usually strikes right after a patient takes antibiotics. If the stool toxin is positive, we don't just guess at a treatment. We follow a very strict algorithm. We start with oral vancomycin. Notice it has to be oral. That's crucial, so the medicine stays inside the bowel to fight the bacteria directly. If, and only if, there is zero improvement, do we escalate our tactics and switch to a drug called fidaxomicin. Now, when it comes to chronic inflammation, distinguishing between the two main types of inflammatory bowel disease, Crohn's disease and ulcerative colitis, man, it can be incredibly frustrating. They share so many overlapping symptoms, like diarrhea, weight loss, and even extra-intestinal signs like joint pain. But we can use specific serologic blood markers to cleanly separate them. If the ASCA test is positive, it strongly points to Crohn's. If the ANCA test is positive, it's ulcerative colitis. It's just a fantastic example of using targeted tests to definitively ID our suspect. Section 5, the acute abdomen, surgical emergencies. Finally, we hit the true emergencies. This is where the medical detective steps aside and calls in the surgical strike team. Time is tissue here, and surgery is often the only definitive cure. Let's revisit the right upper quadrant for a second. Say a patient has severe pain, but now they also have a high fever, and their skin is turning yellow with jaundice. We are absolutely no longer dealing with a simple gallstone. A stone has actually escaped the gallbladder and lodged deep in the common bile duct. This causes acute ascending cholangitis, which is a life-threatening backup of infected bile right into the liver. This demands immediate IV antibiotics and an emergent procedure called an ERCP to physically pull that stone out and decompress the duct. Back down in the right lower quadrant, we are always on the hunt for acute appendicitis. To catch it early, before it ruptures, we use rapid-fire physical exam maneuvers to purposely irritate the abdominal wall. With the Rovsing sign, we press on the left side of the abdomen, and surprisingly, it causes pain on the right side. The psoas and obturator signs involve moving the patient's hip and leg to stretch the muscles right beneath the inflamed appendix. These signs act like little tripwires, basically confirming our prime suspect is ready to blow. But honestly, perhaps the most terrifying suspect of all is acute mesenteric ischemia. This is essentially a heart attack of the gut. A blood clot, usually from atrial fibrillation, just blocks the main artery feeding the intestines. The hallmark clue here is a massive mismatch. The patient is screaming in excruciating, agonizing pain, but when you press on their stomach, it feels totally soft and normal. The pain is entirely out of proportion to the physical exam. If you miss this clue, the bowel dies. It requires an immediate drop-everything trip to the operating room. Section 6, the final diagnosis. Let's close our case file on the medical detective's approach to the gastrointestinal tract. The source material for this explainer, which is actually designed to train physicians, highlights a really profound truth about clinical decision-making. Medicine is vast, but the absolute best approach to diagnosing severe abdominal pain relies on clarity, not controversy. We take this complex web of symptoms, apply strict algorithmic thinking, and always rule out the most dangerous suspects first. We separate the benign from the deadly by knowing exactly which tests to deploy and exactly when surgical intervention is the only way out. So, after exploring these medical mysteries all the way from the top of the esophagus down to the lower bowels, and observing the really careful balance of initial tests, accurate diagnostics, and life-saving interventions, I have to ask you, the next time your stomach hurts, what is your body really trying to tell the detective? Thanks for exploring this with me today, and keep questioning those clues.